Hi, my name is Michelle Cho. I chose ventilator-associated pneumonia as my topic for Nursing 451 individual presentation. As an ICU nurse, I encounter with a lot of vented patients, and ventilator-associated pneumonia has been interested topic for me for a while. What is ventilator-associated pneumonia? Ventilator-associated pneumonia, which is called VAP, is considered as hospital-acquired infection. Pneumonia that occurs 48 to 72 hours or more post-endotracheal intubation. VAP is estimated to occur in 9 to 27% of all ventilator patients in the hospital. VAP is more likely caused by multi-drug resistant bacteria and emerges after 4 days of intubation, according to American Thoracic Society. As Pdsa planning part of the presentation was to see what we need to do. The plan was to see the 35% of MHG Memorial Hospital Gardena intensive care unit patients are ventilator dependent patients, and clarification of nursing and respiratory professional role in vent-dependent patients were critical to be aware and be touched by these two professionals. Policy and procedures for ventilator bundles. These were the critical care ventilator bundle that was available in our website in our hospital. To do gather information, I surveyed 10 ICU nurses for their knowledge of VAP and what they think of what they how to prevent ventilator pneumonia, associated pneumonia. And these were the feedbacks. And according to this elevated head of bed, oral care was the highest. They believe that it will prevent the VAP. And the smallest one was deep suctioning and prophylactic antibiotic. There was also gathering information on respiratory therapists, survey 5 respiratory therapists on how to care ventilator patients in their expertise on nurses to prevent the pneumonia VAP. Plan was to do in service once policy and procedures were created. Study. Prevention for VAP, according to the Klopmas research in 2014, the best of the prevention was to avoid intubation, which is the truth, minimize sedation, maintain and improve physical conditioning, elevate the head of bed, and maintain ventilator circuits. More research on VAP was done. An educator, my preceptor, and I involved educator to set up monthly tests for ICU nurses and respiratory therapists to take a test to expand our knowledge, which should be coming in a few months. Study evidence-based practice quality results shows the high quality results were non-invasive positive pressure ventilator and interrupt sedation daily. That was something that I was surprised with. Assess readiness of extubation daily basis. Perform spontaneous breathing trials with sedative turned off. Change ventilator circuits only if visibly soiled or malfunctioning. Moderate quality results were manage patients without sedation whenever possible, facilitate early mobility, and utilize ET tube with subphloric secretion drainaging port. From this EBP quality result, one thing that was surprised in the high result was change ventilator circuit only if visibly soiled and malfunctioning, because that part, changing the ventilator circuits, it can be an open portal to more bacteria and germs can enter into the vulnerable patients. Enact. Policy and procedures were introduced, and education department verifies, and from that one we plan to take make the test for the ICU and respiratory therapist by educator and post it in our SharePoints to improve their knowledge and then after everything is set, medical executive committee governing board will make any changes that needs to be changed on the SharePoint critical care procedure policies. These were the references that was used during my research: American Thoracic Society, state-of-art ventilator-associated pneumonia, and how to prevent, strategy to prevent ventilator-associated pneumonia, National Healthcare Safety Network on NHS and protocol clarification. Thank you very much.